Hi everyone, my name is Nikolai Schnitke and I'm the Ultrasound Fellow in our Emergency Department this year. This is going to be the first in a multi-part series introducing the use of pre-hospital ultrasound and how we're going to do this on our med flight system. We all know that in our line of work, we don't rise to the occasion, we sink to the level of our training. And even though doing ultrasound is not as complex as landing a jet in crosswinds, it still requires a certain amount of training and making sure that all of this goes as smoothly as possible so that when you're in a critical situation in the field, you're not left scrambling for the knobs and trying to figure out how to do the exam. So the point of the talk today is going to be to introduce the history of pre-hospital ultrasound and critical care ultrasound, as well as how we plan on actually implementing this on MedFlight. And then in subsequent talks, we're going to talk a little bit more about how to actually use the machine and how to get the right images. Let's start a little bit with the history of critical care and pre-hospital ultrasound. Ultrasound in general started shortly after the Titanic crash in 1912, and after that, a number of scientists said, wait a second, we know that dolphins use sound to find faraway objects. What if we use the same kind of sound technology and made sure that we can identify icebergs before we actually hit them? By the World Wars, sonar became quite widespread for finding enemy submarines and navigating the seas. And then after the World Wars, some physicians said, well, why don't we use the same kind of sound technology and echoes in order to look inside of a patient's body? In 1954, they designed the first kind of bulky ultrasound machine that you can see here that requires a big computer to interpret how long that sound takes to come back and actually make an image. Now, computers slowly started to get more and more compact, and by the 90s, the computers could fit kind of right by the bedside, and now a lot of doctors who take care of critically ill patients like surgeons, ED docs, ICU docs, decided to bring this technology to the bedside to look at those critically ill patients that were dead or almost dead. So that's where critical care ultrasound started. This is in patients who have direct compromise to their ABCs that aren't stable enough to go to the radiology suite. Over the years, we found that we can actually identify a lot of different kinds of shock, including hemorrhage, tamponade, cardiogenic, and hypovolemic shock, and also look at causes of dyspnea, looking for pneumonia, pneumothorax, edema, PEs. All in all, this kind of encompasses a lot of the things that we see both on MedFlight and in the emergency department and critical care units. So how is this actually done? There have been a lot of protocols developed over the years to look systematically at different causes of compromise to the ABCs. One of these is called the EFAST, which stands for Extended Focused Assessment by Sonography in Trauma. But really, you could do this in medical patients as well. In this exam, you look at three regions. First, you start by looking in the most dependent parts of the abdomen, looking for free fluid, which in a trauma situation is presumed to be blood. Next, you look at the heart to look for pericardial effusion and see how the heart is pumping. And finally, you can look at the lungs to look for a pneumothorax or other pulmonary pathology. So this is great. We're using this in the emergency departments, in our trauma bays, and in the ICUs all the time. But is this actually feasible in a pre-hospital environment on a cramped little helicopter or in the field? A number of studies have started looking at this, and one of these studies looked at specifically feasibility and how ultrasound performs in aeromedical transport. In this study, what they found is that ultrasound in the field was 99% specific for hemiperitoneum and pneumothorax, meaning when they saw this on an ultrasound, they're pretty sure that it's there. They also found that ultrasound was 50 to 64% sensitive for significant hemiperitoneum and pneumothorax, meaning ones where the patient actually went to laparotomy or required a chest tube in the near future. So we think this is feasible, although not perfect at ruling out pathology, but is it actually useful? Does it actually change management? Another study looked at that specific question, and what they found was that in this 5-year retrospective study with physicians doing ultrasound, about 45% of missions where ultrasound was used, management was actually changed by the ultrasound exam. And these changes in management can mean a lot of different things. It can mean change in resuscitation, change in triage, change in destination, or just communicating the results of the exam to the receiving team. So we think this is useful, we think this is feasible, we think this is doable, but how are we actually going to do this on MedFlight? For the rest of the talk, we're going to talk about what we're going to use for the materials, meaning the machine that we're going to use, how we're going to train everyone up in order to make sure that that landing goes as smoothly as possible, and what the process is going to be for doing the exams and documenting the exams appropriately. Let's start with the materials. We're going to use something called the Lumify probe. This is a probe that plugs in directly into an Android device, And what we're going to use is a phased array probe. This is traditionally thought of as a cardiac probe, but can really be used to look at the lung and the abdomen to be combined into an extended fast exam. We already have these in place, and we're soon going to start doing training on this. Our training is going to have 3 prongs. The first is going to be these videos that you're watching. This video plus 3 more videos looking at how to use the machine, how to scan the abdomen looking for free fluid, and how to scan the thorax looking for pneumothorax or hemothorax. Once you're done with that, you can scan with me or Brian Jeanette in the emergency department, just scanning patients who are sitting around waiting for their workup to be complete in order to get better at doing these exams. And finally, once everything is up and rolling, we're going to have a quality assurance process where I go and review all the images that we acquire through an online archive that we'll talk about later in this talk. In addition to training, we need to talk about certification. ACEP specifically has minimum criteria that they recommend physicians meet before they start using ultrasound clinically. What ACEP recommends is that physicians actually acquire 25 scans of any particular indication. So, how are we going to do this on MedFlight? There's going to be 3 pathways. If you're a UW faculty who's already certified in the FAST and lung exams, you're good to go. You've already met those criteria. Now, if you're not in a UW faculty, if you've been certified in the FAST and lung exams using those ACEP criteria in the past, and somebody in the past has vouched for you, I still want you to watch all of these videos and complete the 10 full EFAST exams so that I make sure that we're all doing this the same. If you have no certification or training, don't worry about it. Watch these videos, complete 25 full EFAST exams with me or Brian Jeanette with one-on-one scanning, and we'll get you ready to go. Now, when I say 10 full EFAST exams or 25 full EFAST exams for certification, what is it that I'm talking about? Traditionally, we think of point-of-care ultrasound exams as being binary questions. Yes or no, is there intra-abdominal free fluid or blood? Here on the right is a positive image with a lot of blood in the intra-abdominal cavity, and on the left is a nice negative image showing no free fluid. But what do we do when the anatomy of the patient or some other problem or blemish gets in the way? For example, here's an attempt at a FAST exam, but there's a huge rib getting in the way of all the areas of interest. This is an equivocal exam, and that's okay. For the purposes of certification, what I want you to do is to acquire all the required views, and then the most important part is interpret it correctly. And if the correct interpretation is that the views and the exam is limited or equivocal, just say that, and that'll count towards your 25 exams. Another frequently asked question is, what if I know how to do a FAST exam, but I've never been trained to do a lung exam? In that case, just watch the video lectures and then do the 25 lung exams. And those are pretty easy. We'll do them down in the emergency department. I don't think it'll take too long. What about other exams? So not under the auspices of this EFAST exam. For example, sometimes we get called to the field for some kind of medical event that occurs in the field. Let's say you get called to a 60-year-old guy who has severe tearing back pain. He collapsed on his farm. He's hypotensive, and the nearest hospital is an hour and a half away. What you're really worried about, obviously, is a huge leaking or dissecting AAA. And you know that you can use ultrasound to find one of these. Unfortunately, sometimes you get false positives. This was a real case of a patient with a very similar presentation that was seen at TAC. The provider immediately called vascular surgery, and the patient was rushed to UW, where vascular surgery met him, placed a Foley in his bladder, and he immediately stopped vagling. This wasn't a AAA, this was actually a really distended bladder. For this reason, I really want you to only do these exams if you've been trained in them, whether here or somewhere else, and please document them because that'll help us get better and make sure that we don't make the same mistakes over and over again. If you're not trained in a different exam, please don't do them unless you really think it's unethical for you to withhold an exam from a patient. Next, let's talk about the process of how we're going to operationalize this exam. The first thing you're going to do when you decide to do an exam in the field or on the helicopter is turn the machine on and start saving scans. Once you get back to the ground, you're going to end the exam, and there'll be instructions for how to do this attached to the machine itself. Once you end the exam, the study is going to get uploaded to a middleware called QPath. Here, you'll be able to actually input the patient's unique MRN and then dictate the results in the note and fill out a worksheet with your findings. This stuff is going to help us do ongoing quality review and also will help us do some of the research to figure out what's actually useful in the pre-hospital environment. So that's it. The series is landed. Today we talked a little bit about the history of critical care and pre-hospital ultrasound and how we're going to train and operationalize this in the field. Next time we're going to talk about the physics and how the machine actually works. And then we'll have 2 talks about how to get a good image of the abdomen and thorax. Here are some of the references. Thank you very much. We'll talk next time.